So, good morning to all. Please apologize my voice this morning. So, my name is Hélène Boisjoly. I'm the Dean at the Faculty of Medicine at Université de Montreal in Montreal. And I have been coming to the World Health Summit now since 2012, and I am a member of the Executive Committee, and our university in Canada has held a regional meeting a few years back. And this is really a great meeting. So I have the privilege to chair this panel session on migrants and refugee health. We have a great panel for you here this morning. As you all know, there are more than 1 billion migrants and refugees all over the world. These are people that require health care, have difficulty accessing to health care, and well, there have been migrants in history. Canada, we are all, most of the people are came from other countries, but now this is really accelerating in the world, and we have to see how we will manage that. So let me tell you how we will work this. Each of the speakers I will introduce very briefly. You have their bios in the program. We'll have 8 minutes to, they have selected cases from their organization that show their current observations of the situation. Please wait until the end for the questions. So when the 5 speakers have spoken, then we will have an open discussion, and you will be most welcome to interact with the speakers. So let me start with Dr. Zsuzsanna Jakab, who is a WHO Regional Director for Europe. Prior to that, she served as the founding director of the European Center for Disease Prevention and Control. She came here during the second World Health Summit, because this is the 10th, at the time when she was a state secretary at the Hungarian Ministry of Health, Social and Family Affairs, when she was managing her country's preparation for accession to the European session. So please welcome Dr. Zsuzsanna Jakab.
Good morning, ladies and gentlemen, and let me say how pleased I am to be back to the Global Health Summit, which I attended twice before. And as this is an anniversary, the 10th anniversary, I would like to congratulate to all the colleagues who have made the Global Health Summit such a success, and congratulations also on this anniversary year. First of all, let me tell you that I would like to talk to you about the public health challenges and response to refugee and migrant health in the European region. And let me start very briefly by setting the scene. The WHO European region is a large geographical area which consists of 53 member states, and it has different types of migration flows. One of the major groups of migrants is the labor migrants. The total population of our region is 919 million. Out of this, almost 10% are international migrants, and the proportion of international migrants in the region has been increasing from 3.9% to 10% over a period of 30 years. This translates to the fact that 1 in every 10 residents in the region is migrant. Let us briefly look at the health profile of the migrants in the European region. In general, I would like to say that refugees, asylum seekers and migrants do not pose an additional health security threat to the host communities, and they do not bring any exotic diseases with them. Initial screening, of course, upon arrival can be an effective public health instrument, but it should be non-discriminatory and non-stigmatizing and carried out to the interests of individuals and the public. We have quite a lot of data about the health of the migrants, but mainly in two diseases, HIV and TB, which are widely studied by the member states. Looking at the proportion of migrants in the field of HIV, among the newly reported cases, about 21% comes from the migrants. There is an emerging evidence that a significant proportion of migrants, even those who originate from high HIV endemic areas, acquire HIV after arrival to the European region. Therefore, it is very important to ensure that migrant-sensitive services for prevention and HIV testing, as well as access to care, are provided to the migrants. Then, with regard to TB, the number of proportion of TB cases among migrants has increased since 2014, and it is now 8.2% of the new cases. And they may have been exposed to TB prior to their immigration to the European region. Refugees, migrants, and asylum seekers are considered as a vulnerable at-risk group, and as with any vulnerable groups, it is essential to ensure good access to healthcare services for the migrants. With regard to immunization, there is a high chance that refugees and migrants arriving to the WHO European region may not be immunized before. Our evidence from Greece suggests that nearly 80% of the newly arrived migrant children have an undetermined vaccination status. And you can see on the map which are the countries that give access of migrants to their national vaccination and immunization programs. And this is, of course, crucial both for the migrant health, but also to protect the public health in the European region and the public health of the resident populations. Moving on to non-communicable diseases, evidence shows that the duration of stay in the host country is associated with the development of overweight and obesity, especially among the North African migrants. Migrants have increased risk of developing type 2 diabetes, and diabetes prevalence is typically higher among the female migrants. The majority of migrant groups are at higher risk of ischemic heart disease and stroke than their native population in Western Europe. Looking at the mental health issues, I will not talk about maternal and child health because I am sure that the colleagues after me will address this topic. Looking at the mental health issues, it is an important aspect of migration and health, as the migration process has a detrimental effect on different aspects of people's lives and the social network that they live in. Therefore, the post-traumatic stress disorders, mood disorders, and depression are the most frequently reported among the migrants. Interesting to note that drug and alcohol abuse, compared to the European population, is less seen among the migrants than in our host populations. There is one more important message here, and that is the fact that evidence shows that post-migration stressors, such as the length of the asylum application process, unemployment, and isolation, are usually negatively associated with developing depression and other mental disorders. Therefore, it is important to underline and focus on these post-migration stressors. Then, let me also say a few words on what we do about this in the European region. Our region was the first WHO region which developed a fully fledged program on migration and health to assist member states with their public health challenges. The program operates under the umbrella of European Health Policy Health 2020, and it provides support to member states in four major areas: in technical cooperation, health information research and training, partnership building, advocacy and communication, and capacity building. And the purpose of the program is to promote collaborative inter-country approaches to migrant health and to facilitate cross-country policy dialogue and encourage homogeneous health interventions, both to protect the health of the migrants, but also to protect the resident population. So we are doing quite a lot of work to create evidence-based. We are collecting evidence even on those issues that are not collected by the member states. We synthesize this existing evidence and make it available to policymakers in a user-friendly way. We have so-called synthesis reports on 9 topics by now. They are all on our website. The most recent one is to address communication barriers. Then later on this year, we will publish an overall comprehensive report on migration and health in the European region. Then in addition to this, we are producing technical guidance to member states on selected topics where they have requested our support. And presently we are working on 7 areas for technical guidance. And then another pillar is to do capacity building, and we have different webinars and WHO schools for this, most recent one with 80 participants, 25 countries, and high-level faculty. And one more thing that I want to mention to you is that we do country assessments using a unique tool that was developed together with UNHCR and IOM to assess the health system capacity to respond to the large influx of refugees and migrants. In Europe, we have a migration and health strategy, which was adopted by the 53 countries 2 years ago in 2016, which deals with all these aspects that you can see on the slide. And every 2 years, we monitor the implementation of this strategy and action plan. We have done quite a recent one, and we have seen some success, some progress in 2 areas. One is to integrate migration and health into the overall health policy, and the second one, then this includes also access to health services and financial protection and access to public health programs. And the second one is to develop contingency plans for large arrivals of refugees and migrants. And finally, let me also say that the work, as you know, is ongoing to develop the global compact on migrants and refugees, and will be discussed and agreed in Marrakesh later in the year. WHO is contributing to this process, and globally we are working on a framework for migration and health and an action plan also, which is inspired by the work that we have done in the European region. We are overseeing the consultation process with member states, and this global framework of WHO will be one of the implementation tools for the global compacts as well. Thank you very much for your attention.
Thank you. Thank you, Dr. Jakab, for this very good overview of the data currently now in Europe. Now, let me call upon Mrs. Mena Barling, Director of the International Planned Parenthood Federation. She has a wealth of senior-level experience in sexual and reproductive health and rights. She was part of international efforts to ensure medical abortion was available for all women and worked on legislative reform relating to women's reproductive rights. Mrs. Barling.
Thank you. I'm definitely not talking about dementia prevention or stroke because it's totally out of my wheelhouse, but I can certainly talk about sexual and reproductive health. So thanks for inviting International Planned Parenthood Federation to participate. We are an organisation present in about 170 countries and locally owned through our member associations. And our goal is to reach need wherever it is, and also with focusing on migrant and refugee populations. We do this by responding to crises as they arise, And many of you would be very familiar with what happened in Indonesia very recently. So in that example, we have a static clinic and program, but then we ask our national staff to surge and respond to that situation, but also to prepare for many of those existing community members who will ultimately probably migrate out of that area. And that has really particular challenges for sexual and reproductive health care. In saying that, we also recognise that many of those community groups will stay and require sustained services while other people move around them. And so our approach ensures that we work across the entire management cycle, so mitigation, preparedness, response and recovery. And our role is to ensure that people's reproductive dignity and safety is a concern for us always. And what we see in highly mobile populations, especially across borders, is that there are different approaches to people's reproductive health care. And women are often, especially women, are put into places where they are vulnerable to reproductive coercion. So what we saw, for example, if anyone is following what is happening in Venezuela and Colombia, we are seeing a lot of women and girls coming across the border who maybe had some level of reproductive health care before but have an ongoing need. And we had a case of a woman last week who was fleeing with her 3 children. Her husband had stayed in Venezuela. She has 3 children from ages 7 to 13. They had gone through ultimate checkpoints. She wasn't using any contraception. She, at every checkpoint, she gave the money that she had, and by the 6th checkpoint, the only thing she had left to give was her body. So by the time she came to one of our clinics in Colombia, she had actually come to us for an IUD, a contraceptive device, but she actually found out she was pregnant. And so in that instance, she decided to use medical abortion to end that pregnancy. And then we were able to ensure she will be able to use contraception afterwards. But what it shows us is that for many women, their health needs are changing every day, and it is not just about preventing an unwanted pregnancy or ending one. It is also about how we ensure how we can prevent against sexual and gender-based violence, which is a really big reality for so many women during migration. And we are trying to offer these services at a time where sexual and reproductive health is increasingly politicised. So on one level, we've got the largest number of women and girls who are either fleeing or migrating for whatever reasons, and we have the most vulnerability in terms of funding to provide those services. So as many of you know, our agenda is at the mercy of a bunch of very angry white men sitting in the Oval Office, and so we're trying to program around that political reality, which for some organisations like ours, we've decided that we can't take US government money at the moment because of what it means for those women and girls seeking services. And we expect to see an increase of vulnerabilities and harm as a result of what's happened with sexual and reproductive health funding and where it will flow to and where it will not flow to. At the moment, 500 women and girls living in emergency settings lose their lives because of preventable causes related to reproductive health. Many of these women lose their life from the indignity of an unsafe abortion, which is entirely preventable. And so these life-saving services are often compromised or denied. We do have, for any of those familiar with this work, you would know, there is an interagency working group on reproductive health in crises, and part of the role of this working group is to mitigate some of those risks that I just mentioned. We have sexual and reproductive health care partners that come together, and in the first 48 hours they do an assessment of what is required. And then the role of that working group is then to ensure commodity and services to respond to maternal health needs, unintended pregnancy needs, transmission of STIs and HIV, unsafe abortion, sexual and gender-based violence. It's an evidence-based program. We try and do it in every country where we are in these conditions. We try to make sure that care is comprehensive, accessible and inclusive, and it addresses the reproductive health needs of all population groups, which means women, men, adolescents, the elderly and the disabled, without discrimination. So for people of all ethnicities and religions and sexual orientation. So that's just a quick snapshot of what our role is. And to end on that, for all of us here, we must remember that all people, including refugees, have the right to sexual and reproductive health. And to exercise this right, affected populations must have the access to sexual and reproductive health information and services so that they can make the decision best for them, regardless of the situation. Thanks.
Thank you, Mrs. Barling. So we have just spoken about women's health. Maybe later during the discussion we will speak further about women and as weapons for war. But now to the children, and I would like to call upon Susanna Kruger, who is CEO and board member at Save the Children. She was with us also last year, and her talk was well appreciated by the group. Before she was with Save the Children, she founded and led Good Roots, an advisory firm working with social investors on their impact, measurement, and organizational change. She is also a fellow of the Global Public Policy Institute here in Berlin, where she contributes to humanitarian aid evaluation. Mrs. Kruger.
Thanks so much. Ladies and gentlemen, thank you for having me, having Save the Children here at this conference. I wanted to remind you something, I'm going to start with something. By the end of 2016, more than 65 million people around the world have been forcibly displaced from their homes, and 1/3 of that, approximately 28 million of this are children. We tend to forget that most of these refugees, or only maybe half of them, are children. The number of children living in conflict zones is also up, from 1 in 10 in the early 1990s to 1 in 6 in 2016. After fleeing their homes, many children on the move do not have access to healthcare and other essential services, and also miss out on education. And the experiences these children make range from the lack of access to food, to healthcare, education, to the loss of loved ones, and exposure to extreme levels of violence. And these experiences, ladies and gentlemen, not only have direct impact on children's physical health, but also to their mental health. And that must not be underestimated. We, as Save the Children, we work all over the world to help these children on the move and to raise awareness for the growing issues of their neglected health. And that's why I'm here today, to give you 2 brief examples of what that means, one from Iraq and one from Germany. So this is the technicalities of PowerPoint. Okay, I don't know how to use this. Save the Children, I start with Iraq. I just brought you some pictures, so that we can see how we do it on the ground. Save the Children conducted research looking at the impact of Iraqi children's mental health in 2017 and 2018. So what did we find? Research from 2017 showed that children and families were living in constant fear for their lives. 90% had lost a loved one. Children interviewed at the time displayed clear signs of toxic stress. This is something that we see in all of our programs all around the world. And our research from 2018 shows the impact of the multi-stress environment they were in and continue being exposed to. So children have not only lived through war, spending their formative years under ISIS or in displacement, but also have returned to new challenges that remind them daily of their traumatic experience. The homes they returned to were often inhabitable, schools damaged and destroyed, access to safe drinking water and electricity limited, and children also reported to find dead bodies in the streets. In West Mosul, where we primarily work, 73% of households reported living in damaged shelters. So this is the reality the kids and children we work with are living in. So children there were displaying symptoms associated with accumulative stress, showing anxiety, problems with sleep, concentration, and in addition, the mental health of parents had been so badly impacted by the conflict that children had been left with very little support, severely limiting their ability to break out of the devastating cycle of ongoing stress. Many children that we see and work with are struggling to return to school because half of all schools there have been destroyed. Nearly 1/3 of adolescents reported never feeling safe at school, and only a quarter said us they thought it was a safe space. So school is no longer seen as a protective environment for these children, and it's hard for them to feel safe in the classroom and therefore to learn and thrive. Iraq's population is comprised mostly of children and young people, with nearly 60% under the age of 25. And we think that the future of countries depends on the development of its children into healthy and secure adults, and that's why it's imperative to ensure children have access to essential services, that they can feel safe to walk around, play outside, and go to school. The second example that we experience in Germany with our work with children and migrants is the following. Of the almost 800,000 requests for asylum submitted in Germany in 2016, 1/3, again, were children. And we have both worked in emergency shelters as well as analyzed the situation of children in them. And while in Germany, accommodations or emergency shelters ensure basic health care to children and their parents, the quality are drastically different, and they vary on factors, for example, such as even the availability of translators, the capacities of overworked staff, parents that cannot share the information needed on their child's medical history. Therefore, children with chronic conditions, for example, diabetes, they do not receive sufficient and appropriate medical attention. Access to rehabilitation is very difficult and not supported by the German state. and this results in a lack of social participation and also, in our experience, to isolation. Another example is access to psychosocial support. While now safe from bombing and immediate threats to their physical safety, children continue living under stressful conditions in these shelters and suffer from fear of deportation, as well as anxiety as to the reunification with their families. Often parents themselves suffer from trauma and are not able to identify or satisfy the needs of their children in this psychosocial area. Similarly, social workers, we experience, are not trained to identify mental health issues, which therefore often remain unidentified. What does that mean for our work in Germany? First, if we are serious about the right to health, child refugees must receive the same level of medical care as the majority population does, irrespective of the duration of their stay in Germany. Second, urgently and chronically ill children, as well as children suffering from psychological or mental conditions, must be identified upon arrival and, if necessary, be immediately referred to the appropriate specialists. In closing, we at Save the Children see a growing number of child refugees with severe health issues, many of them psychosocial, and we therefore advocate for universal health coverage and resilient health systems in all contexts. And we strongly believe our development and work goes hand in hand in supporting our work on emergency readiness, response, and recovery to ensure children have access to the continuum of care in a crisis, how we call it. This applies to both cases, Iraq and Germany and many others, and this is why we think the health aspect of children and their families on the move is of utter importance for national and international public health. Thank you very much.
Thank you, Mrs. Kruger. As you can see, we are presenting cases from all over the world. And now let's move on to Mrs. Karlee Silver, Co-Chief Executive Officer for Grand Challenges Canada. Priorly, she was president of the programs in Canada for Grand Challenges, and she enabled the programs, investment, and knowledge management teams to support and implement innovation for social impact in low and middle income countries. She represents Grand Challenges Canada in the Grand Challenges Network and advises on global mental health initiatives. Mrs. Silver.
Thank you very much. It's a pleasure to be here. My first, although it's the 10th World Health Summit. And thank you for this very important topic to discuss. Just a little bit about Grand Challenges Canada. We are dedicated to supporting bold ideas with big impact. And we're funded by the Canadian government and other partners. And really what we do is to find bold ideas, so science, social, business innovation, that can overcome some of the largest challenges in the world. Our primary objective with this innovation is to save and improve lives. And we support gender equality in all aspects of our organization and in our programming. And concretely what we do is we define grand challenges, so these significant barriers that if we can overcome them will lead to transformational change. And we've heard a really good kind of illustration of that today that I'll come back to around the humanitarian context, the migration and the refugee context. We launch innovation challenges to find the best ideas in the world. And Grand Challenges Canada traditionally has focused on low and middle income countries as a source for innovation. This is not traditionally how it's done, but 70% of the 1,000 innovations that we've supported to date have come from low and middle income country innovators. So it gives you a very different perspective on the kind of solutions that we might pull out here. Based on evidence for those initial kind of ideas that we support with seed funding, we selectively invest in the most promising of them to catalyze scale and sustainability. We're never going to be the ones that put some millions and millions of dollars behind an idea, but our main role we see is to essentially support an innovation long enough that it can be attractive and taken up by more traditional actors, governments, other impact investors, etc. We model and measure the impact that we're having in these innovations. Often when we talk about innovations, people kind of get to the point of saying we funded this many and we're not really sure what's going to happen because innovation is in the future. We think that we need to advance from that, and the ability for us to be able to know when we invest money that we're actually going to get a likely return on social impacts is really important. And so we've developed a model to be able to do that. And then we accelerate the impact of these innovations by working with the innovators and with partners around the world to make sure that those innovations are supported and actually brought to scale. So to date, we've funded about 1,000 innovations in over 90 countries, and these innovations that we've supported to date have the potential to save 1.6 million lives and improve up to 35 million lives by 2030. We've leveraged $2 for every dollar that we've invested, which is an important sign of how much we work in partnership with other people. So bringing us back to this context, the humanitarian context, we've heard a very eloquent description of how large this problem is. And the one that really hits me is the number of people on the move is the highest level since World War II. And I think if anyone, we're sitting here in Berlin, and Ai Weiwei is now lives in Berlin, and if anyone hasn't seen his film Human Flow, I would highly recommend it as a very thoughtful but emotionally kind of emotional evoking kind of film and description of what a person that's going through or society is going through this are feeling. The gap in humanitarian funding is also enormous. So for example, in Yemen, where you've got about 22 million people who are being affected by the conflict there, there's almost $1 billion gap in the funding needed just to actually support those people. And same thing in Syria, 13 million people, and the funding gap is almost $2 billion. And so when we see these things of, really large spends, they still are spending a lot of money in these places, but it's not enough to actually meet the needs that are there. And that we're also seeing that there's only a 1%, not even 1% spend of innovation within the humanitarian budgets. And so it's this perfect setup for us to keep kind of always behind on what we could do. And the role of innovation is therefore to come in and try and figure out how do we do things more effectively, faster, cheaper, better, so that each dollar we're putting into that system is actually getting you more impact in the outcome. So we thought that we had a role to play in this in terms of bringing a grand challenge approach into it. And in 2016, we launched a consensus building process amongst international experts in the field as well as affected people. So a Delphi method to define the grand challenges in humanitarian aid. The top 10 of those were published in Nature in July of this year, and you can look at the lead authors of Abdullah Dar, who's done a number of these that have all led to significant investments in innovation following them. And in February, we were thrilled to join forces with 3 visionary partners, USAID, OFDA, UK DFID, and most recently the Dutch Ministry of Foreign Affairs, to launch the Creating Hope in Conflict, a humanitarian grand challenge. And so through this, we're actually finding enabling innovation that is going to save and improve the lives for the most vulnerable and hardest to reach people in conflict-generated humanitarian crises. We went straight for the ones that are most hard to reach, that are most affected by these crises, and the idea is if we can design solutions for these spaces, that they will likely have relevance to less acute situations where people are still in great need. We have 4 focus areas: water and sanitation, energy, life-saving information, and health products and services. And in April, we were thrilled to see that we had received 615 applications from 86 countries. So these are just their ideas coming in. And we had 48% of those coming from low and middle income countries, and almost a fifth of them coming from conflict-affected countries themselves. We had about a third led by women, which is okay, but not enough. And so next time we'd like to see a little bit more of that. But when we did select the 23 seed awards that will, or the innovations that will receive seed funding this round, we were thrilled to see that almost half of those were led by women. And I think one of the things that we learned through this process is, was really well captured by one of our reviewers, who put it as, the magic that happens when you have a Burmese doctor, a former head of MSF, an executive from MasterCard, a professor from Johns Hopkins University, a health specialist from a government agency, a former UN official, a Syrian refugee, and a venture capitalist, all sitting around the same table discussing these innovations and where essentially we can make a difference. So I'm going to tell you about 3 that came out of this process. 2 that came out of the process, and 1 that I have to bring into the mix because it's close to my heart. The first one is called Surgibox, and it's essentially an operating room in a backpack. And so this is really trying to get around the fact that patient safety, provider safety, and surgical capacity are all incredibly limited in humanitarian conflict zones. And the high risk of infection due to lack of protective equipment and non-sterile facilities can just amplify the injuries that are being felt in these areas. And unfortunately, as many of us have seen in the news, that despite kind of the codes of war, that humanitarian locations are not supposed to be targets, surgical facilities have been more targeted in past. And so it's key to minimize the footprint and simplify supply chains in order to have people be able to have surgery. And so the Surgibox is actually an ultra-portable, inflatable surgical environment that fits in a backpack. And it's literally blows up around the patient and then provides an access for the provider through a surgical, a sterile environment. So the provider doesn't have to be in surgical or any sort of protective wear. The patient themselves has minimal prep, because we're looking right at the area that is actually being operated on, and it inflates with sterile air to be able to undergo the operation pretty much wherever else you can find the rest of the things. So they're going to be testing this, both the manufacturing as well as the rollout of this in humanitarian context, to see how much this can actually reduce the barriers to access for surgery. The second one is looking at prosthetics of lower limbs. So thousands of people with disabilities end up in refugee camps and in surrounding regions of conflict zones because of the use of IUDs and other, sorry, I always say that wrong. What is the right term? I'm missing it. The improvised explosive devices, IEDs. There you go. And essentially, this is a real challenge where you need most of the time highly trained prosthetists and prosthetists, and specialists in orthotics to be able to fit a young child or an adult with lower limb prosthetics. And very few people, the 3D printing for prosthetics is something that's come out more and more in the last years. Most of them are focused on upper limb, and this group is looking at actually doing this for lower limbs, and very specifically for how to actually operationalize this within refugee camps in a way that will be able to provide very fast prosthetic services for people who need it. And the last one that I want to pull in, because I'm thrilled that I'm not the first one who's mentioned mental health on the stage. This is critical for how we actually can move forward with supporting people who have lived through conflict and are migrating as a result of any reason. The traumas that they see and have to live with can be life-changing and can often be carried down generation to generation. And so I think it's really important that we understand how people can be supported with their mental health. And I want to call out one that we've supported through our global mental health portfolio to date. which is focused specifically on Lebanon, and actually the fact that about a quarter of the people in Lebanon, like pretty much everywhere else in the world, suffer from mental disorders. But unlike some other places in the world, almost 90% of these are unable to access treatment. That's due to stigma. It's due to really long wait times, a 6 to 29-year wait to get a specialist in mental health in Lebanon. High out-of-pocket expenses that are required, and substantial delays in actually, low levels of mental health literacy, which means people don't even try to go seek out services, thinking that maybe there's nothing that actually can be changed. And then you add on top of this the health infrastructure that is really being strained as a result of the influx of refugees that have come in from Syria and Palestine. And so the innovation here is actually, how do you design a system, a mental health system, that can really actually take up a lot of the issues with the refugees coming in, but actually be sensitive to the fact that the local health system is not very good at dealing with these problems to begin with. And so they focused a lot on a very rapid train-the-trainer model that actually can roll out interpersonal therapy across Lebanon. And it starts with people who are trained to deal with the humanitarian crisis, but is actually open to the host population as well. And it's an interesting way to be thinking through how can we make these influx of people and welcoming people who are fleeing terrible things happening all around the world to be a positive thing for host communities as well. I'm going to leave it at that, but look forward to the discussion afterwards. Thank you.
Well, we can't talk about migrant and refugee health without having the Red Cross at the table. We are extremely fortunate today that the Secretary General Elhadj, as Secretary General of the International Federation Red Cross and Red Crescent Society, is here with us. Mr. C has extensive experience in leadership roles in the humanitarian sector at senior level with UNICEF, UN AIDS, Global Fund to fight AIDS, tuberculosis, and malaria, and several other agencies over the past 25 years. So thank you, Director General, for being here today. We're looking forward to you to wrap. You see the gender equity here today, so we have one man amongst us. Thank you.
Thank you very much. I was in great company. I had 5 points, and my colleagues, made 4 of them. So I fully agree with you. So let me then just make some comments and put certain things in perspective, and maybe some concrete examples of what the Red Cross and Red Crescent movement is trying to do. First of all, we hear about the numbers and the figures, the 65 million, the up to 1 billion, migrants, altogether. Numbers and figures will never tell, the full story, behind, each of these individuals. Because behind each unit, there is a story of a child, like we've heard, a story of a father, a mother, proud fathers and mothers, like you and me, that overnight, will find themselves, having a different identity because of situations they do not have any control over. And here they are, called migrants, here they are called, refugees. But these are not identities of anybody. These are just situations that each of us, could find ourselves in if we had the misfortune to just, be born in those places where there are so many shocks and hazards that will force us to flee home because home is no longer safe, or force us, to flee environmental shocks and hazards, or simply force us to flee poverty to try to recover something which is very important to each of us, which is our human dignity, to care for ourselves and to care for our families. Well, if we look at it from that perspective, then migration should not be seen as a problem that we will have to solve. It has to be seen as a situation that we need to understand and we need to manage. And managing that situation is focusing on the people in those, situations. I think that's where, the health issue, come in. And the way sometimes, unfortunately, we see migrations, or people in the move in general, it is portrayed as a problem from a perspective of, certain recipient, countries. But where are the migrants and the refugees today? We talk about the migration crisis, in Europe, but where are they? Where are the refugees and migrants? They're in Uganda. They're in Lebanon, where 1/3 of the population is composed of refugees. They're in Jordan. They're in Turkey, where you have 4 million, refugees. And most of them are not even outside of the country. They're inside their countries, moving from one place to another with the hope that home will be safe one day, for them, to return to. Again, when we bring things, in perspective, let's just, put the human being at the center of it and then put it in a perspective that will allow us maybe to reflect on what are those safe spaces that have to be created so that people's need can be responded to, and among them, of course, the health needs. And that maybe should force us, to maybe depart, from the perspective that to see migrants, as problems, or to see them, as carriers of health problems. But what about them also being seen, as, simply solutions also to those problems? Well, we hear a lot about, the health problems, of the migrants, and even in that, often, there is the underlying factor of the association, migrations, people on the move, refugees, and health problems. Of course, I hope for their own sake, but often sometimes, the health threats they can pose, to others. I think, each of us is allowed, to fall sick sometimes and to be treated for our own sake. Well, I think migrants should be allowed also simply to be sick and then be treated for their own sake before they're being treated in the spirit, to protect others, from disease, because that's often, that the way they are being, seen. So we in the Red Cross and Red Crescent, we are a movement in 191 countries. Of course, that means in every country of origin, in every points of transit, as well as, in the country of arrival. And the reason why I'm saying that, if we have to consider, migration and migration health, we have to look at it all the way through the continuum of the countries of origin, the points of transit, as well as, the points of arrival. But the difficulty in doing so is the simple fact that, often migration or a migration situation is not a normal situation. It is not a normal situation, because there is nothing normal, like my colleagues were saying, for having, millions of children and accompanied minors, in situations where they're witnessing things that a child should have never witnessed. There is nothing normal, of a proud father and mother, finding himself or herself, one day lining up 40 degrees, in the shade, carrying a bag of rice, or then being, treated, in shacks, asked about questions about, her reproductive, health, talking about, the mental, situation. Those are not normal situations. But we will have also to develop strategies that will allow us, to work in those normal situations and then respond, effectively, to the need, of people. And to do that, we have to consider what those needs are, and most of the time, those most important needs are denied, of those people, and among them, they are the health needs. And why? Because sometimes we categorize, people, among the legal ones and then the illegal ones, the ones, that are managed, by the conventions, including the Geneva Conventions, and the other ones, that are considered to be illegal. Well, no human being is illegal. That's what we really believe in, and I think that will be an entry point for us, to respond to the needs of the people and then to their health needs. They themselves, see this very unhappy association between migrant and refugees, and health. And I've seen it many times, this summer, when the Aquarius, was, from port, to port until they landed in Valencia. You see that in the refugee camps I visited in Sudan. You see the terrific health stories, that people are, telling us, about, in Libya or even right here in Europe, in Karlee. So the dignity and safety of migrants is often, violated because, again, it is not a normal situation. Then, as, it is a fertile ground for a lot of criminal activities, including human traffickers, human smugglers, all forms of, abuses, against, women and then children, that is paving the way, that very dangerous way, of, migration. So, having said that, in addition to what my colleagues, said, well, we have to look at the health services to which refugees and migrants should have access to. So, of course, emergency first aid and health care is extremely important because, again, this is a very painful, travel that people are undertaking. Psychosocial and mental support, key. The point has been very eloquently made. But also because, as we know, the migrants, often live through armed conflicts and witness, deaths of close, family members and friends. And then to try to regain a certain level of normalcy, simply put, is one of the biggest challenges, that, people, face. Well, we treat many of the wounds, that people are experiencing, including, the physical trauma, but they will have to live, and for a long time, with so many invisible wounds, that we will have to make sure that we see, detect, and accompany even in the long term. It is also about addressing the barriers, to the services. Language, is one of those, as simple as that. Some cultural, barriers, as well. And cost and awareness, and the fear of simply trying to access, the services, because sometimes access to a service, may lead, to an arrest. So, too quickly, I understand I have 1 minute to very quickly two examples. Establishment of neutral and safe spaces, including safe health points, for migrants, are very critical. So we have some very interesting experiences to share that we can share outside of this room, led by the Italian Red Cross. The protection of the health of the most vulnerable migrants, especially women and girls. My colleagues mentioned that. But we have very interesting experiences in Niger that we would like also to share. And migrants and refugees do often what I call the 3D jobs, which are the dirty and the difficult and the dangerous, jobs. And that in itself, present a health hazard to make sure, that also, health and then the health of migrants, is addressed, in that area. Well, let me just conclude by saying, migration and migrant health, is very important that it cannot be left to the health sector alone. It has to be addressed, from a different perspective, and it calls also for partnership. Partnership, like the different perspectives that colleagues are bringing here around the table, but also, a partnership, to accompany them, all along the migration trail, all from the countries of origins to the countries of arrival. And in that spirit, we pledge our presence in 191 countries, 17 million volunteers on the ground, to partner with you. Thank you very much.
Thank you very much. So we have about 25 to 30 minutes for a discussion. So if you have questions, I understand there are microphones that will be made available for those who want to ask questions. Please introduce yourself, identify to whom you want to ask the questions. Because this session is being streamlined, I will ask the speakers to go to the podium when they answer your questions. So I see one hand or two hands over there. So the microphone.
Thank you for the nice speech. My name is Selma Harada. I am professor of public health and coming from Istanbul Medical Faculty, Turkey. As you know, we have at least 4 million refugees in Turkey. In general, Turkey is accepted as a transition country, but 4 million most of them Syrian people, have been living at least 5 or 6 years in Turkey, and so they are permanent, not transition. Of course, in the beginning, Turkey is not prepared such a big migration wave, but later Turkey has reflected in many ways. For instance, health and social services are completely open to migrant population in Turkey, but unfortunately only to Syrian refugees, not for the other people coming from another other countries, etc. And as usual, NGOs are so active.
Yeah. Please come to your question for the panel.
I don't have any question. I want to explain our experience from Turkey, if it is okay for you. I don't have any question.
No, okay.
Okay. And so, as usual, the most vulnerable people are always women and children, and for instance, different sexual orientation, etc. Child working is very important problem in Turkey, and the high fertility rate of women is very common, unfortunately. Early marriage is another important issue. As conclusion, I would say that supporting much more supports is needed, especially to help the most vulnerable people in the countries. Thank you.
Thank you so much for describing the Turkey situation. Would one of the panelists want to comment?
I go there.
Yes, please.
I just want to make a very short comment to say that we work very closely with the Turkish government on these refugee issues. And there are two elements that are very impressive in this work. One of them is that there are a large number of Syrian doctors in Turkey among the migrant population. And Turkey has made a real effort to integrate these medical doctors and also the nurses into the Turkish health system. So after a few months of training courses, they know the legislative system and all this, and they are fully operational in the country. And they are the ones who provide the health care to the Syrian refugees who are based in Turkey. And I think this is a fantastic example, which we use as a good model also in the other countries. The other thing is that we are very active in Gaziantep, in the south of Turkey, to reach out to the northern Syria, because during the war that was the only place from which you could reach the children of North Syria to immunize them against polio and other infectious diseases. And we have been working very closely with Turkey on this, and I really acknowledge a lot the Turkish approach to the whole migration and health issues. Of course, there are also some other countries in Europe, in spite of all the difficult political discussion that is ongoing, where we have seen a lot of incredibly good work. Before a few months, for example, Italy was a good example of this. Also, Greece was a good example, and the Nordic countries, particularly Sweden. So a lot of chapeau and acknowledgement to the countries who are doing the way that they should do, and all the countries should do, to respect the human values of humanity and the rights of refugees.
Thank you. So one hand.
Yeah, thank you very much. Andreas Wolf from Medico International. I'm a Global Health Project Coordinator. Thank you very much for addressing the mental health issues of the refugee health so clearly. Maybe one point I would like to add, and also questions in how much you can advocate for it, because we feel in Germany, particular part of the mental health problem is not only coming from the terrible experience and trauma on the way or in their home countries, but also because the unsecure situation that is created by residency policies of Germany, for example, or other European countries that prevent refugees really to calm down or feel that they are now in a safe situation where trauma could also be addressed. So it's not only an issue on access to quality services dealing with this. And my question would be to ICRC or WHO, how much they can use their channels, influences and communications to address these issues also with European governments, or how difficult it is also in a diplomatic environment to stress these points, which are outside the immediate health issues, but of course as health in all policies would be something we would see it very much. We would like it very much if the international organizations can be more outspoken or join efforts of civil society to do. Thank you very much.
Please. If you have a question, just...
Yeah, I was just mentioning before that it is important, to work all along the continuum, from all the way from the countries of origins to countries of arrival, because indeed, the shocks and then the deprivations, are faced at all levels. And you are absolutely right. Mental health issues are not only because of the trauma people experienced, before, but because of the shock of integration. The possibilities, that are being created at the point of arrival, or not, the extremely difficult, bureaucratic, processes, of recognition, or even sometimes just the fear, to engage in that process, because you may qualify, you may not qualify, or the trust, you may have in the system, as a whole together, that is driving so many underground, not only underground from a legal point of view, but underground in terms of also the health-seeking behaviors. What we do, yes, fully agree with you that we need to continue to advocate for that. That's what we do. We need also to, as I said, not just to consider it as a health issue, but looking at also the political dimension, the administrative dimensions in all of it. But also, as I said, we are present in all those countries of arrival. We have a National Society of Red Cross or Red Crescent in each of those countries. And then we engage in mental health accompaniment of those people, including right here in Berlin and also many other parts in Germany through the German Red Cross, like we do also in Turkey with the Turkish Red Crescent and in any other parts of the world. Are we making progress? Yes, it is enough. Definitely not. We will have to continue together do the work. Thank you.
An additional comment from Susanna Jakab.
If I may add, fully agree, absolutely agree. And what we see is that the migration and health issues, except maybe for reproductive health, are not so much politicized. At least the public health aspects, they are not politicized. So, for example, to give access of migrants to immunization programs or integrate them to tuberculosis, HIV prevention screening programs, also to give access sometimes to healthcare, not in every country, it's not a political issue. But the whole environment, the whole political environment around it is politicized in many countries, and it is very important to upkeep the human rights issues here, and also the European values and all the values that we have been pursuing so far. And this is why in our European strategy we advocated for intersectoral collaboration, high-level political leadership. This is what we try to bring in also in the global framework. And that's why it is so important that the Global Compact on Refugees and Migrants is coming out in Marrakesh, and hopefully it will be adopted, because in this Global Compact we have also included health. It was not an easy process, but we have included health. And health will be interlinked with all the other important political elements. So that will help us to move forward also in those countries where the migration and health issues are politically motivated, and there are quite a few of these, but we have to focus on this, and I fully agree with you that we have an important role, all of us, to play in this process.
Thank you. A question. Please.
Thank you. I'm Christopher Bazivamo, coming from the East African community. East African community being Kenya, Tanzania, Uganda, Rwanda, Burundi, and the Republic of South Sudan. This is a regional economic community in an integration process. So in that region we have also refugees, and I am glad I have heard it from Mr. C. We have them in Uganda, we have them in Kenya from Somalia, we have them in Tanzania from Burundi. So we have more than 5 million refugees throughout the region. Similarly to here, let me first of all appreciate the panelists for insight, information, and presentation on the work they are doing. In general, what I want to emphasize is the issue of prevention. Sometimes we deal with symptoms, but we do not fight the root causes, and it is important to cater for that. One of the ways of putting people on board is awareness creation. Sometimes we are focused on our activities, but we do not put enough energy, enough funds when it comes to awareness creation to bring all stakeholders, or most of them, on board so that we address the situation together. And here I think we should look into our budget and see how we balance what we put in the real action when it comes to give curative measures and what we put in the side of awareness creation and in the prevention processes. And here I think it is important to build also capacity of refugees so that they can themselves be able to cater for the problems. Otherwise, if they are always in sick situations and in weak situations, and they cannot address some issues themselves, and you think we will be the one to cater for that, then it becomes a bit difficult. So the issue of capacity building, we think it is very important, and the issue of bringing all stakeholders together is very important. You have spoken about vaccination, this is important, but what I call upon to you is to look into our budgets and see what really we put in the prevention mechanisms instead of focusing only on the curative measures. And by bringing people on board, by speaking about what is happening, by bringing even members of parliament here, members of parliaments here and there, so that they are on board and speak loudly because they are paid to speak loudly about the situation, and in the oversight processes, take accountable our government to ensure we are doing the right thing. I think this will be a proposal which can maybe serve as recommendations in whatever we are doing and the conclusions of our discussions here. Thank you very much.
Thank you. So on empowerment of the people, because these multiple situations are all over the world, how can we better empower the people who are in these situations? Any comment? Yes, but because of the stream, they will not be able to see.
Yeah, I was just really briefly, I was going to say that one of the key things from the Grand Challenges approach is that we're really looking for ideas that come from the people who are most affected by them, by the challenges that they're facing. And some of the things we get are just incredibly creative and so embedded in the cultural context that they're emerging from that they couldn't have come from anywhere else. One of the things that I would say from our first round, we were extremely excited to see 20% of the applications coming from conflict zones, which is an incredible feat for people to put together, even if it was a short application, to put together an idea when you're living amongst all this other chaos that's going on. The thing we wanted to see more of was actually really manufacturing or creating kind of solutions from within. And we've had some amazing ideas of that people have pitched us since then about how potentially, like, instead of flying jumbo jets of IV fluid into areas in order to deal with cholera, how could you potentially have small machines that are able to actually be producing IV fluids within conflict zones? So that's an example of something that we would really love to see more of, and the ability for people to be actually proposing the key areas within health or energy or water and sanitation or life-saving information that most resonate with them is something that's of great desire for us to see. So we'll launch another one in February 2019, and we would love to see anyone around the world, including those in conflict zones and refugee camps, to respond. Thank you.
Another comment on empowerment of the people.
Yeah, very briefly, sometimes it is not even about empowerment, but just recognition, because, fact of the matter is, migrants are not only there to seek for services and then seek for help, they're also service providers, and that many of the reasons, why people are moving around is to provide services, to others. I mean, the number of because you talk about East African community, I could talk about SADC. The number of Malawian nurses, and doctors, around Manchester, it's much more than all the Malawian nurses in Malawi, altogether. I mean, if you open the yellow pages, of New York City areas, and you go to the letter K, the number of Dr. Kwasis and Kwames and Kwajos, could stuff, all the, areas of health services in Ghana and Cote d'Ivoire, together. If you take, the number of Filipino nurses, in the Gulf, like in many other countries, the health system in those places, will be quite shaky. And Susanna was talking about the Syrian doctors, in Syria, in Turkey, and in other, parts, of the world. It's also about recognizing, the skills and aptitudes that exist, within, the migrant community, unleash those, and allow them, to be put to use, because there are so many administrative and other bottlenecks, to allow those also to put their skills, into practice. When you have a Syrian doctor, highly qualified, that needs to also do another 5 years of training, in a place before starting, to practice, there is something that to be questioned. And I think part of the empowerment is recognizing, the skills, the capabilities, in that community, and create an enabling environment, so that, those skills, can be put to use for the benefit of both the migrant community as well as their host, communities.
The last question from the audience spoke about the root causes and prevention. Susanna Jakab will comment on that.
Well, thank you for raising the root causes. This is a very important issue, and we have to continue to invest into those countries from which the migrants come from. And I'd like to acknowledge the good work that the European Union has started to do in this regard to create jobs and employment and all this, and that has to continue, obviously. However, having said that, The migration is also a kind of population dynamics which has been always with us, and this will continue to be with us. I gave you some figures on my first slide when I said that in the European region, over 30 years, the number of migrants increased from 4% to 10%. And this was not due to any crisis situation. This was just population movement, labor migrants and all this. And this will continue to be the case. So therefore, when we look at this very important issue, on one hand, we should look at the emergency and humanitarian element. On the other hand, we should look at the development element as well. And this development element is very crucial so that we integrate into the overall policies, health system strengthening, the access to care, the access to prevention, as you mentioned, and also the financial protection of the migrants. So this is my last comment. I promise I will not take the floor again. Thank you.
A question. Well, I think you had your hand earlier on. Please.
Thank you very much. This is Clement Staub, representing the Swiss administration. I have another question for you, Ms. Jakab, so maybe you have to take the floor again. You mentioned the Global Compact on Migration, and there's also the Global Action Plan of WHO, and which is in consultation among member states at the moment. Could you elaborate a bit further on the connection of the two, and and the status of the process and your position as WHO Europe? What your priorities and recommendation would be, and I'd be also interested in the position of the IFRC on that matter.
Sorry. So there is no direct connection between the Compact and the Global Action Plan. The Global Action Plan was requested by the countries about 2 years ago, and we have started to work on it. It's very much inspired by the European Action Plan, and basically to put migration and health on the agenda of WHO as a whole and all the different regions, to ensure the same issues, the development issues, the access issues, the public health issues, and also the financial protection, because in WHO now the key strategic direction is the universal health coverage, and as we always say, there is no public health without migrant health, no public health without refugee health, so if they are not integrated into all the work that we do on public health issues and health system strengthening issues, universal health coverage, financial protection, reduce out-of-pocket payment and all this, then we cannot make progress on this. So the whole WHO strategic framework, the global one, and the action plan that is developed, it serves this purpose. But at the same time, this global compact in the UN came up, and we felt very strongly that the health element should be integrated into the compact. And it was a difficult negotiating process, as you can imagine, because every sector wants to have its priority included, but finally we managed. So now there is the final intergovernmental process around this global compact, and if everything goes according to the plans, it will be adopted at the end of this year in Marrakesh, in Morocco. And then this global action plan that we develop will be one of the avenues to implement the global compact. And we inspire it from the European perspective as much as we can. Thank you.
Okay, thank you. While the microphone is being brought at the end of the room, there was a hand. I have a question for the panel. There are many students in the room. There are deans from schools of public health and deans like myself of schools of medicine and health professional. We agree that the migrant situation is there and will be increasing. What can you tell our schools to, how can we improve our education program so these health professionals are better prepared for the migrant situation? All schools now are talking about social accountability. These are words, but in practice, do you have suggestions for for academia?
I have a small suggestion. I think people who are studying should step away a bit from academics sometimes and go where it happens. So I would suggest strongly that people go into refugee camps and really experience what's going on and how people and kids feel. And also I had one smaller comment before to the colleague from Medico, I think it was Medico. And you asked us as NGOs how we can advocate for more psychosocial support and the importance of that. And we have to tell more stories about that. I think in Germany we are on a very meta level discussion. You know, we are speaking about like we are overrolled by migrants and by refugees, but very few people actually understand what it means to flee a country. And I think that is something that we could advocate more for, tell more stories and get the people in contact with each other. I think that would help a lot.
Yeah, I think that's very important. And the schools now are really encouraging, their students to go out and see what's happening out there in the world. So if there are no other comments on this, there was the last question probably in the back.
Thank you. Thank you, Chair. I'm Dr. Niknam. I'm representing the Medical Academy of Sciences from the Islamic Republic of Iran. Iran has been the host for hundreds of refugees from Iraq and Afghanistan. And through years, we helped them in the different areas of their need, including health services. Based on the international statistics, among 40 million registered migrants and refugees, about half of them are from Afghanistan and Iraq, both neighbors of Iran. My country, during the several recent decades, has been the host for 3 million refugees from Afghanistan, 1 million registered, and about 2 million not registered. This large number of refugees in Iran directly and indirectly put a heavy financial burden on the shoulder of the health system of the Iranian government. By saying that, I would like to stress to the importance of more financial contribution of High Commission for Refugees, UNICEF, and other health-related UN agencies. Lastly, I would like to share with you some experiences regarding mother and child health care. Our experiments through these years show that strategies for better accessibility, as a matter of fact, of health services to refugees and immigrants should be focused on activities including expanding preventive health services, focused on children and pregnant women, offering family planning services, offering necessary services supporting safe delivery at related facilities or at home. Thank you.
Thank you. Any comments? I mean, I think we all agree on this. Let's see. One last question. Here. Sorry.
Thank you very much. I'm Zsuzsanna Slamka, and I'm an early career researcher. And my question relates back to a couple of notes we heard about empowerment and best practices to help improve migrant health. But something that occurred to me during the discussion and like even the questions is that from time to time the narrative or the discussions we are having about this issue includes an us and them separation. So, and this is, I guess, this also relates to the communication about the so-called migrant health per se. We identify a community and we identify them as separate from us, who then have the services and who have a separate, certain set of values which are European for me at the moment. For others, it may be completely different. So my question is, how do you think we could? What are the best approaches to involve them in the discussion, to be in a communication in which their voices are not only made visible by us, but are being heard because their voices should be heard?
Who wants to speak on this? It's one world, one health. How do we get there?
I think I raised this earlier of the importance of making sure that our organisations that respond with service delivery are actually staffed by the same communities that they are serving. And so for International Planned Parenthood, we've tried to be very deliberate about how we design those responses and with who we design those responses with, especially as there is some sensitivity with the services we provide, and what women and girls need might be in stark contrast to what others want for them. So I think the most obvious response is how we work together from the start.
Thank you. Well, this ends this panel session. I hope you have enjoyed it, and let's give a round of applause to our 5 panelists.